Mudit and everybody?
Sir, we are live, sir. We can start.
Okay. Okay. Good evening, friends. Welcome once again to the unique Delhi CSI PG track program after a gap of 1 week. And that was because of the exams that happened. I think our all fellows performed reasonably well. And now we have new batch of fellows. Second year becomes third years, first years become second years, and the learning is an ongoing phenomena. So we have come again with a whole new program starting from the basics. And today, in the 20th webinar of this PG track program, we have the pleasure of having Dr. Ranjan Shetty, who is joining us right from Bangalore Manipal Hospital and speaking on jugular venous pulse. And we also have the pleasure of having Professor Sumodh Kurian, who's professor of cardiology at JVP and Hospital. We have the pleasure of having Dr. Array Manigam, Associate Professor of Cardiology at JVP and Hospital, my colleague, Professor Girish MP, Professor of Cardiology and Joint Secretary of Delhi CSI Cardiology Branch. And we have many of our residents and fellows joining live here on the panel for the question answers, and many of them live on the YouTube and also on the webinar link. So over to you, Dr. Sumodh, for starting the session. And we look forward to a great interaction. And feel free to ask all the questions. If you have any questions, please type them. They will come to us, and we will ask all the questions to the panelists and also to the to Dr. Ranjan Shetty. Over to you, Dr. Sumodh.
Yeah, as we all the DM exam, and one need to have clear concept how to measure JVP, how to identify the waveforms, how to do an abdominal jugular reflex. So there are so many things that you need to be very clear about. And today, as Mohit has introduced, Dr. Ranjan Shetty is with us. He's the head of the Department of Cardiology at Manipal Hospital. He's a very good teacher and very able to lucidly explain, various mechanisms and all. He's very good at that. So it is our great pleasure to welcome Ranjan to do his presentation. Welcome, Ranjan.
Thank you. Thank you, Dr. Sumodh. It's actually, and thank you, Dr. Mohit, Dr. Girish. It's a real pleasure to be here in this. And, Dr. Sumodh was my teacher. I've learned a lot from him. He was our senior, both, during our MD names, and then as he was senior resident when I was doing MD. So I learned a lot. So it's a real honor to be part of that. And Dr. Mohit, congrats to you for all your hard work and the effort you take in all those small details. I really appreciate your enthusiasm, and you have not made it easy for me. You were very specific in what I should speak, and I spent one day searching for some of the things just to make sure it is up to your expectation. Thank you for that. So I'm going to discuss about JVP today, and as Dr. Mohit has said, we also had conducted a DNB final exam here in our center, in the national exam. We realized that this is very important. There are some topics which can fail you in exam. There are some topics which give you extra mark. When we talk about JVP, apex, parasternal heave, and S2, these four are key, apart from pulse and BP. JVP is extremely important because you can't afford to make mistake in JVP at all. You just can't make any mistakes, and it's very important you know this very well, and it's very important you understand some concept. This is very basic. I'm sure most of you are well aware of our discussion, but I'm going to just go through it. So we will outline it with anatomy, the measurement, causes, normal wave pattern, abnormal, and two important signs, which is Kussmaul sign, and one of them is a reflux, and people keep talking about hepatojugular reflux. Let's slightly discuss about that. Now, what is JVP? The first question to be answered is, all of us use the short form. Is it jugular venous pulse or is it jugular venous pressure? If you ask me, if you have to use one, it is JVP is pressure, you will call it as pulse. But if you ask me, it is both. It is both pulse and pressure. That means there is no, you can't just say normal JVP and get away. That's just not possible. So you need to say, even if it is normal, you will still have to comment. When you say normal, the pressure could be normal, but you will still have to comment on the waveform. So at MBBS level, or maybe at even MD, DNB, MD level, you could just get away with that. At cardiology examination level, you just can't get away with that. The most important is you need to describe. Even normal JVP would have a slightly prominent than V, or some parameter, and it's very important that we use that. It was described way back. I usually don't like talking about the names because it's difficult to remember, but little bit of history is what we should all know. Paul Wood, which is a very important name. If there's one name in cardiology, especially hemodynamic cardiology, if you have to remember, it has to be Paul Wood, and he's the one who understood JVP and gave the hemodynamics of JVP. Now, anatomy, we are all very clear. We should understand where to see, and first and foremost, to understand how to distinguish a venous from arterial. We are looking at internal jugular vein, and we are happy to look at right internal jugular vein for simple reason that this is a direct continuation. It becomes SVC and comes down, and there is no valve, so pressure can be easily transmitted in this condition. And what position we need to show, I'll come to that. This is how it looks. External might look engorged, but because of the valves, we do not measure in external this. So typically it is right internal jugular, and we need to understand right internal jugulars are lateral to the carotid. It's not medial, it's lateral. Femoral is medial. Here it is lateral to carotid. That's something which we should understand. Now, why IJV? This is a question which is almost sure. You need to understand it's a straight line, no valve. Even with increased sympathetic activity, the internal jugular does not get affected. And it's the one which drains the brain. So body has made sure that this vein is reasonably well protected. Left IJV, typically we don't use unless it is a situs inversus dextrocardia, where it should be both situs inversus and dextrocardia. Whenever we talk about situs, remember something. We're talking about atria. Situs, there is abdominal situs, there is visceral situs, there is thoracic situs. But when they say situs solitus, you're actually telling, when you utter that word, you're actually telling right atrium is on right side. When you say situs inversus, you're actually telling right atrium is at left side. So situs is very important. So it's not the dextrocardia which will tilt, it is situs inversus which will tilt. You may see left JVP if needed, but even in then you may have to comment on right. Technically, the advantage is it reflects RA and sometime RV. RV is only when the tricuspid valve is open. We will come to that in a short while, but typically it's been the RA pressure, but RA mirrors RV. Hence, most of the time we are going to get this. This slide, I'm sure all of you know, because this starts at MBBS level, difference between a vein and artery. Remember, artery is medial, artery is superior, little more superior. Artery is deeper, better palpable than visible. And whenever, this is more lateral, more visible and less palpable, many waves, JVP tends to have, it will never be single, whereas artery, you typically see a single wave. There are many waves here, both up and down. A normal JVP, inward is more prominent simply because the blood actually has to go inside the heart. So inward waves are more prominent in normal JVP, whereas outward is prominent. If you have doubt, it is possible, then you could just press the abdomen and see what's happening to the wave. Now, you cannot use hepatojugular reflux. We will talk about that. That's used only when JVP is not raised. But if you are in doubt and you want to distinguish, you could actually compress the abdomen and see what's happening, or ask the patient to breathe and see. See, the artery does not have respiratory variation at all. Artery does not have variation with compression of abdomen. So if you are in doubt, this would help. But typically, this is not the doubt which is important. How do we examine? Patient has to be comfortable. There needs to be an angle. That's what we should understand. Most of the time, there needs to be an angle. Now, how much should that angle be is very difficult. Should it be 45 degrees? Should we take, whatever it is called to measure the angle, and should we keep it 45 degree? Is the 45 degree important? No, it's definitely not important. But if you have it 0, if the patient is lying down 0, then the pressure is in continuation with the RA, and you tend to see all the waveforms which are there. You cannot measure the upper margin when it is 0. But some angle, preferably between 30 to 60, it makes it easy. But you need not measure it because you're measuring the perpendicular height. So if you're measuring JVP, there are two scales. One scale which is parallel to ground and one scale which is perpendicular. If you have one scale and a pen, you should use that scale as perpendicular because JVP is the perpendicular distance from the uppermost margin. So when you measure, you need to rotate the neck slightly to the opposite side, not too much, slightly to the opposite side. They should be in the same, this one. Head also should be slightly bent so there is no pressure on sternocleidomastoid. But remember, angle is irrelevant. It's not the angle because you are anyway measuring the vertical distance. So your top of the jugular venous pulse is what you measure, and this is the scale. So this scale is important. See, the second one is ice cream cone, ice cream stick. It's not a scale. So if you have one scale, make sure that scale has to be perpendicular distance. Now, the upper point is clear. What's the lower point? What is the lower point? What do you measure? Where do you keep this scale? Traditionally, I can tell you clearly that in exam, traditionally, you need to tell that the lower point is actually on manubrium, sternoclavicular joint. But even in Brownwald, there is a modification where it's believed that it is a sternoclavicular joint. So either could be right, and I don't think so. We need to argue too much. Maybe in panel discussion we could discuss, but in an exam, always start with the angle of Lewis, that sternoclavicular joint. And if the examiner asks you, is there any other way, then you should always tell the sternum, this point. So make sure some of the things, the problem is you just don't know what your examiner is thinking, and it's very difficult to predict. There is a lot of difference of opinion among examiners, and also there is north, south, east, west divide. People have different concept as you go different geographically. Dr. Sumodhan, I can tell because we have been trained in North, but I worked in South. So I can tell you clearly there is a difference of way people look at any of the signs which including conduction and radiation of murmur. It becomes very important. So when you're, in an exam, only you can lose. Examiner cannot lose at all. It's very important for you to drive points which are very clear and make your point. And if somebody knows better, if they know the current, this one, they will ask you the second one and you need to answer. They can't cut your mark for manubrium sternum or angle of this. So most people, it is 30 to 60 degree, and that's how you measure. So you measure here and you measure here. This scale is important. Say you get this number. Beyond the sternoclavicular joint around 40 degree, 45 degree, it's always significant. Okay, that's what you should understand. Now, how do you describe a JVP? It's the mean. If there are many waves, it is the mean. Mean means it is where it's going to stay for a long time. You have to make a mental picture, and that's the point which you are going to measure. Imagine it is, say, 8 centimeter above. So how will you describe it? You'll have to call it 8 centimeter of water or blood, to be precise, above sternoclavicular joint. That's how you will describe. If somebody asks you what is the RA pressure, that's something which they will probably ask. Then what you should do is add 5 to this. So 8 plus 5, 13. Again, it will be centimeter of blood or centimeter of water. If you want to convert into millimeter of mercury, because that's something which we do, you need to divide it by 1.36. Now, how do you get this number? That's the specific gravity of mercury. Specific gravity of mercury is 13.6, but you're converting a centimeter into millimeter. So 10 gets cancelled there. So it is 1.36. So 1.36 centimeter of water is equal to 1 millimeter of Hg. You could even multiply by 0.736, but it's basically same. That's based on the specific gravity of water. Important point, Angle is not important. Sternal angle as reference, actually leads to underestimation of venous pressure. So ideally in today's era, it should be from the sternoclavicular joint, but with the caution I mentioned, if you do a study, sternoclavicular joint will be the best marker for JVP, okay? Venous pulsation above clavicle in a sitting or a semi-reclined position is abnormal, but in a lying down, it's not. So that's the point. Imagine JVP is not raised at all. You should still be able to comment on the waves by making the patient horizontal, or in a dehydrated patient by putting the head little down. You can never say, I can't see the JVP or JVP is not seen at all. And this reference, I put it purposely, it is brown wall. So, if somebody asks, remember the answer to this actually comes from brown wall. Now, what are the maneuvers? Remember in JVP, just like pulse, just like, there are 3 maneuvers which you should know. Do not forget this maneuver. You need to comment on after you evaluate, after you describe. Make sure 3 maneuvers are important in JVP. And Dr. Mohit specifically told me to tell this to you. So one is the positional change. What happens when you move, that tells you the upper margin very clearly. Second is the respiratory variation. Any respiratory variation is called phasic in cardiology. Remember, whenever you say phasic changes, you are actually talking about respiration. So inspiratory, expiratory change has to be told. And if the JVP is not raised, only not raised, you need to comment on abdominal jugular reflux. It's not reflex, it's reflux. I'm sure all of you know that. But these are the 3 maneuvers which we use in JVP. Also remember, exam is like rapid fire. I know it because we just conducted. That is the only way your examiner can assess you. So whatever you say, they're going to ask, be ready for next set of 8 to 10 questions or 4 to 5 questions. And quicker you answer, the better answer you get. Never allow your examiner to scoop out the answer from you. For a simple 1 question, if they have to give you 5 clues, you don't get mark. If at all they get mark, so make sure answer is complete, full, and you are trying to tell them that I know my stuff. I'm not trying to compete with you. That's what you're trying to tell your examiner. But I know my stuff, and that is it. Now, what happens to positional changes? Horizontal, any JVP will be heard. Sitting up, even abnormal JVP sometimes can disappear. Now, 2 scenarios are important, and that will be asked again. What if the JVP is very high? Imagine the pressure is above. So you see that earlobe could move. And if it is because of the vein, earlobe typically moves laterally like this. If it is because of the artery, it moves front, back, because the carotid is typically like this. If it is the vein, it goes laterally. Other point which is asked is, if it is still higher, you could raise your hand. You look at your own vein here. As long as you keep it below the heart, it looks full. But as you raise up, it will start disappearing. So if the JVP or the pressure is very high, like in sometimes CCP or RCM, if it is high, if you lift it up, the point where it disappears could be an indirect marker. Not very reliable because there are valves, but if this is a question, this is how you answer. Sitting up is the first thing to do. If it is above, you also see the earlobe moving, and as you raise your hand up, the point comes here. Phasic, that's what we have discussed. Respiratory, inspiratory, fall of jugular venous pulse is very important. But remember, the pulse, the mean falls, but the waveforms becomes more prominent. So you should be able to distinguish a waveform from the mean. So with the inspiration, the mean falls, but the waveform is more prominent. But there are conditions where there is inspiratory rise. It doesn't fall, but it goes up. Now, what could be the mechanism for that, and what are the conditions which cause it? So it can only happen because why does it fall? The thoracic pressure is negative, and inspiration, the blood is actually sucked into heart. So it makes sense that the JVP, the mean JVP falls. But if it has to rise, that means heart is not able to take that extra blood. That's why it is rising. But the key point, this is enough. In exam, if you tell heart is not able to take extra blood and it's rising, it is enough. But for gold medalist among you, I would want to challenge you a little more here. Where is the blood coming from? From up it can't come anyway, because it is rising rather than flying. So where is the blood coming from? Most of us have our own hypothesis. I believe it's the IVC blood, which by cause of the diaphragm gets pushed up, but cannot go to heart because heart just can't take it, and it's going to SVC. I'm sure people have their own hypothesis, but it's enough to tell heart is not able to take extra blood, hence there is inspiratory rise. What is the condition you get? RCM is very classical. RVMI, any RV dysfunction, RVMI, constrictive pericarditis can produce this. Constrictive pericarditis, it's common to find because there is, the pressure doesn't get transmitted to thoracic, pressure doesn't get transmitted to heart, but it is more classical actually of RCM. What are the other methods of JVP measurement? This is again, Dr. Mohit wanted you all to know. I believe you should know. So the dorsum of the hand, which I already discussed, and that disappearing when you dorsum and you slightly raise it and height from the sternal angle, from the collapse, not reliable, but just remember the name. It's called Gertinger's method. When venous pressure, there is a collapse, as you raise it up, you realize, it's like this. You look at this, see where it raises, and that's the JVP. Obviously not reliable, but if it is above this, it is important. And in sitting position, if you have engorged veins below the tongue, or if your earlobe moves out, then definitely the pressure is increased. So these are the same the peripheral vein compression method, but all these are subject to error. But as I told you, exam is all about rapid fire. If you try to tell your examiner, I know these things, typically they will leave you at this point. Please remember these names, and this is a demonstration of how do we show it. So you hold the hand at the level of the sternal angle, it's full. Start raising up, it will disappear, and if you measure this vertical height, that will be a JVP. Very unpredictable and very this. But remember these methods. The other method is anthem or Rizakullah sign. So for it's a little modification of this technique, where arm is passively elevated directly over sternum. You don't keep it away. See, in first you are keeping it away and raising. Here you are keeping on the sternum and slightly raising. And if the vein, as you raise, you expect the vein to collapse. Point at which is collapse, if you measure the direct pressure, that is again a sign of JVP. Unreliable, but if you are good at it, this is for the gold medalist again, please remember it. Okay. Now with this, we'll go into what is a normal waveform. 2-3 things. The thing I like is identifying the waveform, and that's where we need to spend little time. And what are the normal waveforms of JVP? So we have A wave and we have B wave. C is not that important. We have X descent and we have Y descent. No, C is part of V most of the time, and all of you know A is atrial contraction. X is atrial relaxation interrupted by the tricuspid valve coming up or carotid pulsation called C. V is filling when tricuspid valve is closed, and Y is rapid emptying. The beauty of it is it possible for you to spend all the waves? Imagine there is 60, heart rate is 60, and you are supposed to find out all the 4 waves. That means there are 24 to 40 units, events in a minute. Unless some of you are like, Shakuntala Devi, it's going to be tough to do that kind of calculation in your mind. So my advice, pick up 2 waves, any 2. It could be 2 outward, which will be A and V, or 2 inward, which could be X and Y, or you could have 1 outward and 1 inwards. That's very important. Pick up 2 waves. Do not pick up 4 waves. Nobody is expecting you to give 4 waves, at least in the beginning. So when you pick up, how do you find out? So we explained that the JVP actually is picked up on the right side. Okay. So you need to feel the left carotid. Now remember something. Before, after does not help you at all. Whether you're doing it for murmur, heave, or apex, before, after doesn't help, because it's a cycle. Whatever is before will always be after. So if I have to describe something, I look at with and without. That means any wave which comes with carotid, I'm feeling carotid looking at the JVP. If it comes with carotid, that is systolic. If it comes without carotid, that is diastolic. That's how we do it. Now, we should also understand which of them are systolic. Luckily, one up is systolic and one down is systolic, and vice versa. That means A and Y are diastolic. Now A is S4 and Y is S3. No, that is they're the equivalent. So it's very easy for you to remember S4, which is diastolic, which is A, and Y. So outward A and inward Y are diastolic. That means they would typically come without carotid. X and V would come with carotid. That means if you have an outward wave which comes with carotid, answer is V. If you have an inward wave which comes with carotid, answer is X. If you have an outward wave which comes without carotid, that is A. And inward wave which comes without carotid is Y. There's also one more trick if you want to extend. Typically, when it comes with, you don't get confused. If it is without, you start getting confused. Unless you are a confused personality. If you are a confused personality, nobody can help you. But if you are otherwise very clear in your thought, moment you have two events which are not matching, your mind starts getting confused. So if you are looking at a wave and if you are not sure whether it is with or without, it's likely without and likely diastolic. With ones, you don't, don't get confused. So I recommend that most of the time in the beginning, please keep doing it and keep doing it, and also in medicine and cardiology, believing in the science are important. Do not start thinking that this is all crap and we are making up things. Once you do that, you don't pick it up. Simply if I have to tell you, if I have to go offshoot just for a second and tell you, first time when you heard for blood pressure, corpuscle sound, I'm sure none of you heard it. And when teacher was trying to tell you 1, 2, 3, 4, all of you must have agreed that the teacher is actually fooling you. But as you do it, you realize it happens, and now you don't even think about it, you get it up. When it comes to cardiology, whether it is murmur, whether it is palpation, whether it is thrill, or whether it is JVP and pulse, believe me, if you believe in them and if you do it, you will get it right. So please concentrate and use simple tricks so that it is easily available. So we discussed about A, we discussed about X, we discussed about B, and we discussed about Y. We also had a trick. If there is AF, it is very easy because there is no A at all. X also is very submerged because dilatation, relaxation of atria doesn't take place to that extent. So all you are left is with V and Y. So I know most of you get scared if it is AF in exam, but believe me, it's the best thing that can happen because JVP becomes extremely easy if you have AF. Okay, let's go to the next slide. What is A wave? Atrial contraction. I'm going to go a little fast here. Don't worry about synchronous. It is diastolic. And if you keep a ECG, if you in the RA pressure, then it doesn't come with P. There is an electromechanical delay. It actually comes with the QRS. It doesn't come with P. Okay. Now, X descent is systolic. Remember just that prominent font X descent in normal JVP. A is more than V and X is more than Y. But we are not that lucky. We don't get normal all the time. C is not usually visible. Even when it is visible, it's the CV wave. And for theoretical reason, X is split into X1 and X dash. So X descent goes, the C actually cuts it. V is important. CV is when there is TR. V otherwise is synchronous with carotid pulse. Do not worry with S2 and before and after S2. Y descent is very important. Again, it's important to know, is the Y descent present? Is it rapid or is it gradual? Because that is something which will be asked to you in exam. H wave. If you are giving one more need, it's very important. Otherwise, theoretically, no. H wave is a diastatic wave. That means it is between in the diastole. When tricuspid valve is open, the JVP, RA gets communicated to RV, and JVP actually represents RV pressure. It's the mid part of diastole. Very important for MCQ, but not in practice. But remember H wave. How do we identify wave? We already this. I'm not a big fan of heart sound measurement. You could use apex, you could use carotid. Remember, with and without. Okay, that is the key. Timing wise, if you do timing, this is how you'll find. If your catheter is in RA, you're going to get it good. Otherwise, it is this. A and V, what is the difference? Most important, if you ask me, is systolic versus diastolic. Then obviously there are, if you have an ECG and if it is a RA catheter, one doesn't come with P, it comes actually with end of P, that's beginning of QRS. Other one is in the peak of T. Normal person, A is more prominent, but you can see all the variation that's possible. Abnormal waveforms, let's discuss some of the abnormal waveforms. So some of the abnormal waveform is a prominent A wave. There are two aspects here, Canon wave and a prominent wave. Where do you get prominent A wave? You can't have AF, that is the first point. Anywhere RV is in some sort of strain, then RA will have a diastolic component, in the sense it's like either RV failure or RV diastolic. That's when that's when RA will be prominent. Just excuse me for a second, I may have to put a yeah, sorry about that. This was going the brightness was going down. I'm sorry about that. So whenever there is a RV dysfunction, either systolic or diastolic or problem with tricuspid valve, without AF, you get a prominent A wave. So that could happen in tricuspid stenosis, atresia, but AF is common here. Pulmonary stenosis, pulmonary hypertension, RV infection, acute pulmonary, anywhere, systolic, diastolic, RV problem, the A will be prominent. So these are tracings which are seen in, for us to understand better, these are RA tracing. So remember, P is here, but the A comes very close to QRS, and A is extremely big compared to V. There is X descent, there is Y descent. Most cases, A is, if there is a big A, then the X descent will be much more common. Now, what is a Canon A wave? Canon wave is where atria contracts with the closed tricuspid valve. This is one condition where A will be systolic, because it comes with carotid pulse. So this is an exception. Although it's A, it will be systolic. So Canon waves come with carotid. It won't be a V, it will be A. So whenever you have a Canon wave, I'm sure all of you have seen VT and SVT. Canon wave could be a regular Canon wave. That means it comes with each beat. If you have a regular Canon wave, it's actually a sign of VA association. That means V and A are beating together. Could be isorhythmic AV dissociation, could be retrograde conduction producing this, or could be junctional rhythm. Irregular Canon wave, that means intermittently it's coming and rest of the time it is disappearing. That's intermittent Canon wave. That's a sign of complete heart block, VT without VA association, or in just ventricular pacing. Okay, can also occur with ventricular ectopic. So regular Canon wave is a sign of VA association. Intermittent Canon wave is a sign of this. So whether you have a giant or big A, Canon is different. Canon is a systolic A. So this is how Canon comes. You look at Canon along with it comes along with QRS. It is always fine. This is a regular Canon. The best place to see will be PSVT. All PSVTs. If you look at JVP, you will get regular Canon wave. Just see it next time. Irregular Canon wave can be complete heart block. It could be VT, and it could be found in so many. So this is a video which is showing. Intermittently you're actually seeing a very prominent JVP which is coming here. So it's a sign of irregular Canon A wave which is shown in this picture. Irregular Canon. How do you distinguish a Canon from giant A? Giant A is a big A. It's uniform, observed in each cardiac cycle, and it is diastolic. Whereas a Canon wave occurs sporadically or depending on the VA association, but it is mainly systolic. It comes with carotid. This is one more question which will be asked to you. Giant A from Canon A. Now, absent AF, very important. AF is something which is there, but it can also occur in sinus rhythm where atria stand still, maybe post cardioversion or some cases of cardiac amyloidosis. It could be absent. One important Epstein. Epstein has a Himalayan P wave, okay, in ECG, but atria is so big that JVP actually does not rise in Epstein. It will be little opposite of what you think. The atria will be right. So just look at this picture of a RA tracing where A is absent. You have a C, you have a X, and you have a Y descent. You don't have X with the A, so the X is predominantly small or little absent whenever there is AF. What is the abnormality of X descent? Blunting or disappearance is a sign of TR because TR produces merging of CV wave. Prominent, where do you get prominent X descent? This is something which will be asked. One answer is tamponade. But why do you get X in tamponade? Unfortunately, I think we cannot have a discussion now. So X in tamponade is because the answer to that, what wave do you get in JVP in tamponade? Answer to that is X descent. Is it prominent? Is it normal? The answer is it is the only wave which is heard in tamponade. Why? Because the blood can enter heart when blood leaves heart. Again, re-emphasizing systole. Blood leaves heart in systole, and blood can enter only in a descent, cannot enter in a upward. So X is the only thing. So it's a raised JVP with X descent. This blood is only entering during systole because the total volume is fixed. That's the tamponade physiology. Not same as CCP. Constrictive physiology is totally different. I'm sure most of your second year is going to final year, and you might be confused about a tamponade physiology from a constrictive physiology. Remember, they're totally different. I'm sure Dr. Mohit will have some class for you to understand, because they're both X and Y are prominent. Early Y is present. Whereas in tamponade, Y disappears. So you do not get Y at all. The only wave you get is X. Anywhere A is prominent, again, X can be prominent. So this is a JVP where we see a prominent A and a descent. Just to see a JVP like that is sometimes tough because the timing is very important. But you do see a prominent, there is a prominent inward wave which is present. What is the abnormality of V wave? So this is important. V is systolic. When the tricuspid valve is closed, whatever blood goes in produces the V. Since RA is compliant chamber, V is not that big, whereas LA being less compliant actually has a big V. So a prominent V could occur in TR, especially because the CV wave is the biggest. This one in TR. It's also called arterialization of the JVP. Just look at the waveform here. You feel it is a carotid pulse. It's almost like that, and it is outward. And this is the arterialization of the JVP, which is present. We also can, in absence of TR, can occur in VSD, ASD, VSD with the left to right shunt, can occur even in cor pulmonale and atrial fibrillation. And also you should remember RSOV. RSOV to RA actually does not have an A wave because the blood is flowing in systole now. RSOV to RA has prominent V wave, and RSOV to RV produces strain on RA and has prominent A wave. Remember, it's not the same as you might think. RSOV to RV will have an A wave because atria has to contract. RSOV to RA will have V wave because the blood is going into RA now. Okay, and also you should know all the difference between RSOV to RA and RV. Rapid Y descent, that's very important. You have a V. Whenever you're describing, you should treat CV wave and the descent. Is it present or is it rapid? It's absent as we discussed in tamponade. It's present in most conditions. It's rapid whenever there is in TR, it is rapid. Interesting part is what are the conditions where Y descent is not rapid, where the Y descent is delayed. So Y descent is delayed in two conditions. One, if there is a tricuspid stenosis, even with AF, you see a V and Y descent has to be slow. Other one is RV dysfunction. Because remember, in echo, you have a E and a A. Even RV dysfunction, the DT can get prolonged. It all depends on degree of RV dysfunction. If it is very severe RV dysfunction, then S3 will be present. No, you'll have actually a prominent Y wave. But early form of RV dysfunction, where the DT, gets prolonged. Just remember the echo where you have E with DT prolonged, like a grade 1 dysfunction. These are the condition where Y descent will be less rapid. Slow Y descent, invariably exam question again, is seen in RV dysfunction or if it is TS. And also important question is, when do you diagnose organic heart, rheumatic valve? That's the question which is asked. Organic TR is not diagnosed without TS. It has to be low pressure, but the important thing is you should have a signs of T, and that is actually actually a low Y descent. So two condition, RF dysfunction, TS. Most rapid Y descent, you'll get it in CCP because you have both X and Y prominent, Y much more prominent. And this is the reason why you get a pericardial knock. Pericardial knock is because of this rapid Y descent. So it's very important. Slow Y descent, tricuspid stenosis, pericardial tamponade, it is absent, but RV dysfunction. And if you have a RA myxoma obstructing, again, it's like TS. So you will get a slow Y descent. Remember that these are the causes. Examiners love when you give more causes. So more causes, better it is. Pulmonary hypertension, what do you see? It depends on the degree. It could start with a prominent A wave only, but later with the TR, it could have CV wave and a Y descent, which is prominent. So depending on the degree and stage of pulmonary hypertension, but JVP can never be normal in pulmonary hypertension. You will find something. In arrhythmias, we did discuss SVT, you could have a regular Cannon waves, VT, regular Cannon wave, intermittent Cannon wave, bradycardia, sequence will still be maintained. In congenital heart disease, ASD, that's something which will be definitely asked. A is equal to V. Why? Because right side A is bigger than V, left side V is bigger than A because of the poor compliance of LV, which gets transmitted to LA. So together, it's A is equal to V. If the ASD is large enough, if the pressure between two chambers are communicating, then A is equal to V. That's a hallmark of ASD, but it could vary. If there is PAH, A will become more. If there is MR or even MS, because V could be more big even in MS, then the V will be more. So it is variable, but classical is A equal to V. VSD, it does not matter unless it is into LA. If it is in LA to LV to RA, V will be prominent. With PAH, A will be prominent. Otherwise, it's not very prominent. The A and B are not very prominent. Cyanotic heart disease is a different topic. I think I will not be justified in talking completely about it. Remember, talk physiology and such physiology, A is more prominent because there is RV disease. And Eisenmenger, most Eisenmenger, again, A is more prominent, especially older the patient, A will invariably become prominent. ECG also, you get P pulmonale in most of them, but it is again very variable. So Eisenmenger ASD has heart failure, and because of heart failure, JVP gets raised. Could be invariably there is a TR and it will manifest according to TR. I'll share these slides. You could go into this, but it's a different topic by altogether. I won't go too much into that. Important part is, anywhere where there is a restrictive atrial communication for whatever reason, A becomes prominent, like in tricuspid atresia, restrictive atrial communication, the JVPA. But remember, in tricuspid X-ray, you can have a box heart, where heart, A will not be, the atrium may not be very big. You can actually have a box heart because of juxtaposition of atrial appendage. So also make a point, when I used to study, I used to always highlight these points in my mind wherever I could go wrong, because there are points which you will go wrong all the time. Every time you study, you'll go wrong. Just make sure, make those associations so that there is no mistake. Epstein, A is not that big, CVV is big. Because atria is huge, you may not have a JVP with A wave. Okay. Mitral stenosis, the problem is right side, not the left side. PAH will produce AF will make it disappear, and the Y descent is slow in TS condition. MR, again, it depends on its effect on RV. So just short, this one about, pericardial disease, we did discuss. Tamponade constriction are not the same. They are definitely different. Main X descent becomes, it's not prominent, remember, it's normal. It's the only wave. With the raised JVP, since you are seeing X, to you it looks prominent, but it is a normal X descent which is present, but others are not prominent. Whereas in CCP, you'll have a prominent X and prominent Y, and if you have to guess, Y will be more than X, whereas in RCM, X will be more than Y. So tamponade, this is how, if you do the atrial, this is how it looks, and X is the only wave. It's not prominent, and it's the only wave. CCP, we already discussed both X and Y. You get a W pattern or reverse M pattern, and it's very interesting. Kussmaul sign is positive here. I hope this place you could see and you all could make a diagnosis. So what would be the diagnosis here? I'm sure you can't type, but you are seeing two inward waves really prominent with a raised JVP here. So this is likely to be a constrictive pericarditis, two inward. A big chart showing all of them, but what is very important is to understand that the concept remains the same. Whatever we discuss, the concepts remain the same. Understand the concept. It's not about the chart. It's about understanding the concept. Now, the hepatojugular reflux, and I'm sure most of you are very happy because this is almost the end of my talk. So, hepatojugular reflux, also called as abdominojugular reflux. When should we do? When JVP is clearly not elevated. Borderline, yes, but if it is elevated, do not describe in elevated JVP. It finds latent right ventricular failure, or whenever you have a silent ER suspicion, you could make the waveform prominent. How do we do it? Initially, the gentle pressure is put to 10 to 30 seconds. It has, over the years, different maneuvers have been described, but stick to 30 seconds. Okay, 30 seconds. Pressure could be on abdomen, then it will become abdominojugular, or it could be on liver. But before that, you have to find out whether the liver is palpable. It could be painful, so be very gentle when you do this. And this is how you do the pressure. Usual JVP posture, keep your hand on the abdomen or this and give a 30-second pressure. What are the 4 responses? Dr. Mohit was very particular that we discuss this. Please go through this. So 4 responses which we come. One is a flat response, means nothing happens. Nothing comes up, flat response, that's negative. That means it's not positive. Second is rapid return. It goes up and, the second is this. Goes up and rapidly come down. That means you could have elevation up to 3 centimeters for less than 10 seconds. So you have put the pressure for 30 seconds, but less than 10 seconds it comes back. A rapid return is also normal. So 4 response, flat line is normal response, rapid return also is normal. It goes up but immediately comes down. These 2 are normal. But if it goes up and it is sustained either to the same extent or to some extent, whole of 30 seconds, these 2 response are considered positive hepato. So one of them is called trapezoid response. It means it's going to try to come down but not reach the baseline. And second is the square wave, not square root, square wave response. That means as long as you put pressure, it remains up. Both these are abnormal. Both these makes it positive. Now, what does a positive hepatojugular reflex mean? It's very important. It means there is heart failure. Maybe right, maybe left. You're actually looking at right, but it means there is heart failure. So if you have a hepatojugular reflex positive, that final diagnosis when you write RADMS, this. If hepatojugular is positive, you have to write CHF positive present. One more trick. I know this is the first of your session for the next academic year. Remember something. Whatever you do, whatever you describe, finally, it is all about that one line you utter in your exam. People are only going to check whether that line is consistent with whatever you have done. So when you do something, remember, it should have implication in that line. For example, heart rate 110, you don't write tachycardia or uncontrolled this one, it's wrong. Blood pressure more than 140, you don't write hypertensive, it is wrong. JVP right, CHF should be there. Or even if hepatojugular is positive, then it will be called CHF. So I'm going to just go through this once more for you, because this is not easily available. It took us some time to get the slides and put it for you. You should thank Dr. Mohit for that. One is a flat trend response, no change at all. Rapid return, these two are normal. Trapezoid, something like this, is abnormal, and square wave is abnormal. Okay. So this is what it is, and you could use 15 second, 10 second. I would advise 30 second pressure, 10 second. Less than 10 is normal, 10 to 30 abnormal. Elevation less than 3 normal. If it is elevation more than 3, it is abnormal. Okay. I will send you all this mechanism. Yeah, again, like the Kussmaul sign, abdominal blood pushed. Are we not able to take it? The JVP rises, similar to Kussmaul response. Okay, so this is our hepatojugular reflex. You press, you see the JVP going. This is a square response. Now, all the 4 response, square response. It's positive in incipient right heart failure, compensated right heart failure, even LVF volume overloaded, TR, it is positive. Rarely it's false positive if there is a lot of vasoconstriction, COPD, and if the sympathetic tone is increased, then the vessel tone is low. It acts like a pipe and things actually come up. What's the Kussmaul sign? So we described 3 things you should always: positional variation, hepatojugular reflex, and respiratory variation. The Kussmaul sign is increase in JVP with the inspiration. You don't expect it normally. It's like pulsus paradoxus, hence it was described almost together. I did describe you any condition where again RV is not able to take extra blood, the RA pressure rises. Believe me, it's probably because of the diaphragm pushing the blood down, just like hepatojugular, and bringing it up. So let's now come to it's end of the talk. Let's come to the quiz. And before that, if any of our panelists, I'm sure it was very boring for them, because it's such a basic topic for everyone. So Dr. Mohit and...
No, it was a fantastic talk, and we can very well carry on with the quiz. And we have young fellows, and it will be a great learning from them.
Yes.
So Dr. Mohit, if you can ask one by one, I think.
Yes, this is the first question. Whoever wants to answer, and other than Dr. Sumod, of course, anybody.
Okay, Sudhir, you just listen to this particular diagram he just showed. So what do you think this is? Yeah.
Sir, shallow wide descent. Waveform, Y wave slope.
Very good. The Y descent is shallow. So what do you think are the possibilities with shallow Y descent?
Sir, possibilities are tricuspid, maybe tricuspid stenosis, or right atrial myxoma obstructing the RV inflow.
Okay. Third one, RV dysfunction.
RV dysfunction.
Yeah. And also, this is practically an absent Y wave. Remember, this could also occur in tamponade. Okay. But then having this prominent A is unlike tamponade. Tamponade doesn't have a prominent A. It has only, if it was only X descent and absent Y like this, even tamponade was possible. Okay.
Very good. Very nice answer, Sudhir. Now we go to the next one.
Okay.
Ajay Ram can say.
Ajay Ram.
Awesome.
Take your chance. Yeah.
Here
I'm not your examiner, so don't worry.
Here there is the option P wave, sir. Most likely patient having atrial fibrillation, I think. There is P wave is not A wave. A wave is not there. A wave is absent. Mostly patient having atrial fibrillation.
Yes.
One possibility. Then patient along with C wave here, there is X descent is less prominent. And Y descent is more prominent.
Yes.
Okay. Option
Yes, I think, and we didn't put the chart. Otherwise, it's typically RA pressure which we are putting for you to understand. Yes, A is definitely not seen, so AF is there. Whenever there is AF, as we discussed, X also will not be that. This Y is very rapid. So this could be the physiology here. Could be, it may not be just AF. The CV wave also is prominent, no? So there could be a TR.
TR.
Very good. Yes. So pick out the correct response which occurred during inspiration. Yeah.
Shaukat.
If Shaukat is not there, Dr. Surya Kant?
So, jugular venous pressure non. Hello?
Yeah, please tell, please.
Please go ahead.
Jugular venous pressure normally, option A, sir. Jugular venous pressure decreases with the respiration, but there will be a prominent A wave. So, the amplitude of option A, sir.
Very good. Dr. Mohit, I think your students did not need any class.
No, they're not students, sir. They are just,
Oh, they are from all over, or they
all over India. All over
very
India.
nice. Very
some
nice.
of them are here, some of them
are elsewhere. Okay. Next one.
Again.
Sudhir?
It's one of the beautiful JVPs actually. If you look at it, you'll get this one. Take your time and answer.
I am not able to see the screen.
Not able to see? Okay. Somebody is showing it also.
Ajay Ram?
Sir, it's showing prominent outward pulsations. Mostly video, sir.
No, it's very clear by finger is showing.
Okay, extensor, prominent extensor. Inward pulsations, so prominent inward pulsations.
No, it's outward. See, there is what you see. And this is a beautiful wave. I know it's difficult. Don't worry if you get it wrong because you're not timing it. But if you see, there is a flicker followed by an outward pulsation. Whenever you have flicker, that's a A. Then there is a CV wave. See, A, you just look at it. Flicker followed by a big wave. A flicker followed by a big wave. No? So it is actually A followed by a CV and a slow Y descent. That big wave is not followed by a sudden downward. So look at that flicker, you can see it most cases when you have a, but the Y descent is not very prominent. But flicker, you can see that flicker followed by a V wave. I'm sure you'll identify it if you see it yourself. Yeah.
Okay.
Next one.
V wave is more prominent than A wave. V wave height is more than A wave, and there is rapid Y descent.
Correct. And the X is hardly X, no?
Hardly any.
CV wave.
So it's a CV wave followed by a rapid. So it's like the previous case, which if you have to draw, except Y is rapid here. If Y is slow, what do you think?
So TS is there or either
RV dysfunction.
TS or RV dysfunction or myxoma. Okay.
Myxoma.
Okay. What do you see here? It's labeled very well, so I don't.
Irregular Cannon wave.
Irregular Cannon wave, but very not good. A giant A wave. No, irregular Cannon wave. It will be systolic. Now, the next question. You have to answer the most
slow Y descent.
Yes, slow Y descent is the most likely. It won't produce Cannon A wave, but a prominent V wave also is possible. No, it's just the filling, but the most likely is slow Y descent. Okay. So, thank you, Dr. Mohit, and all of you for joining. And Dr. Sumod, any of your Dr. Girish and Sumod, I think they have a lot of experience. So.
No. Ranjan, some of the other questions they usually ask is, many times, the waves are prominent. So should you mention the height of the waves or the mean pressure? So how do we say which what are they actually measuring? Whether you are measuring the the wave height or whether it is a mean pressure. So that is one thing that is
correct. You would like to answer, Dr. Sumod, or it's better if you tell the answer? Yeah.
No, Ranjan, you had read. You tell.
Yeah. No, I see. When we describe, we are supposed to describe the mean pressure. Now, I think Dr. Sumod has a very valid point. How do you get the mean when it's so much flickering? So this is where your imagination is needed. You need to imagine that mean. That is the point from where the waves are going up and waves are coming down. So you need to know that. So measuring that mean is important when there is a flicker. So that's the point where it's going up and down. It's like the baseline which is there in your, which is there in your cat. That mean that you're supposed to describe the mean. So when you're describing it is the mean JVP. Now to make it more complicated, if you're good enough, you're also supposed to describe A wave and V wave above that mean. And if the wave A is actually more than 2 centimeters above the mean, it's a very prominent A above that mean. You're supposed to describe above the mean. You're supposed to know that A is coming till here, but the mean is here. But it is enough in exam if you describe the mean. You're describing the mean and you're telling them that waves are above or below that mean.
Another thing is that Dr. Shetty, often hemodynamic correlates of JVP are asked in the exam. Which pressure does it correlate with and what does it signify? I think it will be pertinent to mention that the positive hepatojugular reflex is indicative of a pulmonary capillary wedge pressure of more than 15 millimeters of mercury.
Yes.
And one thing that we should also be aware is that even the hepatojugular reflux may be present even in the absence of the right-sided heart failure.
Correct.
And that indicates pulmonary capillary wedge pressure of more than 22, 23.
Correct.
So these are the things which are often asked in exams.
In exam, yes. I think that's a very important. There are
what will be the likely pressure in such a patient? What will be the likely pulmonary capillary pressure? Yeah. So this is one of the things that. Dr. Girish, Dr. Arima, you have any point to make on anything?
Ranjit, one more thing. There is a lot of focus on some recent CT studies. Locating the position of RA and all. So sometimes they ask this question also: what is the impact of those studies of CT, MRI, to find the the point of zero level at which we should start.
Correct. Whether it matters on a JVP, whether the measurement of JVP. Yes, I think there are. This is at best an assumption what we do with JVP, because it will not be correct RA pressure at all by any this one, because the body with body habitus, the body type, the midpoint of RA is going to change. But what we have realized now is probably the sternal point is not very ideal. It should be the sternoclavicular joint, the junction of sternoclavicular, which depicts the pressure very well. But to add 5 or more or less, it actually depends on the size of RA. But overall, I think among many signs which we have, JVP does predict heart failure reasonably well, compared to many other. Very few conditions, elevated JVP will be false positive. But you could definitely have a failure without JVP rise. But if it is elevated, invariably there is a heart failure.
Sir. Hello. Sir, I have a doubt.
Yeah.
Surya. Sir, I'm Surya. Sir, you said flatline response in hepatojugular reflux is normal, sir. But if the patient is having hepatic venous thrombosis, if the pressure is not transmitted to via IV, can we say that as a negative response which is taken as normal? Or in case of hepatic venous thrombosis or Budd-Chiari syndrome, we won't get in that case, we will tell negative. But in that case, can we take it a flat wave response as normal, sir?
In the sense, it all depends on the fluid status. If you Budd-Chiari will definitely not allow it to get transmitted to RA. There is no question about that. But flat wave also could be normal. If there is some sort of intravascular hypovolemia, you may not get any response at all. It may not rise at all. The JVP may not rise at all. That's a flat wave response which we are talking about. But Budd-Chiari should have its manifestation of Budd-Chiari, because it's the IVC thrombosis. Just hepatic vein is not enough to prevent this reflux, because you could abdominal jugular, it will be positive. So if there is already a Budd-Chiari, if there are signs of Budd-Chiari, then yes, hepatojugular will not be positive. But otherwise, that will be a flat. But flat also could be normal. If there is some sort of a dehydration where JVP is not ready to rise at all, it could be normal.
Again, I would not perform hepatojugular reflux in patients with Budd-Chiari. It is very, very unusual that probably you will use that.
I think it's important to put everything together and then describe it. That's the point.
Very simple thing that Dr. Shetty, they are asking, which you already made it clear, that the elevation of JVP during hepatojugular reflux is noted during compression for 10 seconds or after releasing the compression.
Yes. So I think it's the persistent of compression up to 10 seconds, up to 3 centimeter elevation is fine. If the elevation even during the initial phase is more than 3 centimeter, or if the elevation persists as long as you compress, then it is abnormal hepatojugular reflux. So that persistence could be trapezoid or it could be square, but any persistence beyond that is abnormal. Yes.
So, any other questions?
I think we should congratulate Dr. Ranjan for such a lucid presentation, excellent presentation. And one thing which I would like to add over and above what Dr. Ranjan has told is in patients with massive pulmonary embolism. So, if there is a ball sort of thrombus in RA, there also that you can have a very gradual white descent.
That's
correct. Because of the RV dysfunction, Dr. Girish, yeah.
Yes, RV dysfunction as well as thrombus.
Thrombus itself, yes.
Yeah, both.
Thank you. Yes, Sumod, anything?
Ranjan, it was a very beautiful presentation. Your practical tips also were extremely useful. Thank you so much.
Yeah. Thank you so much, Dr. Ranjan. Thank you so much, Dr. Girish, Dr. Arima, and Dr. Sumod. And thank you all our fellows who have joined. I hope you have enjoyed this presentation. I have a couple of things that we are coming up with a new series. Absolutely. If you have any particular lecture that you want, any particular topic to be covered, please mail us on the PG Track CSI Delhi branch at gmail.com. And also you can subscribe to the channel PG Track CSI Delhi branch. This lecture will be uploaded there. We will request Dr. Ranjan to be a regular on this, a presenter on this particular track. His expertise. I've listened to so many of his lectures. Phenomenal speaker. And we will request him to take more sessions for all of you. Yes. If you have any particular questions, please write them to us on our email. We will definitely revert back to you with all those things. So thank you, sir, so much for Dr. Ranjan. It's such a pleasure. I think this virtual world has connected and brought all of us together like a family. And academics is really growing and has no boundaries. Let me tell you that though this is a new batch, we have already 328 people who are live to the webinar across the country. So it's a great thing. Thank you so much. Thank you.
Thank you. Bye.
We'll meet up next Friday again with a new series. Thank you.